This is an Anopheles mosquito. Most of you will probably have heard that it's one of the deadliest animals in the world. And you probably know that that's because it transmits malaria. What you might not know is what exactly it looks like when a mosquito kills. Well, this is what it looks like. This is a girl with what we call severe malaria. She will have a very high temperature, she'll be drifting in and out of consciousness, she'll have difficulties breathing, and she'll experience bleeding, and she will be very, very unwell. And yet, she's among the lucky ones, because her parents took her to a health facility where she can be treated and where her chances of survival are about 80%. Many children never make it to a health facility, maybe because their parents live at a great distance from the nearest clinic. Among children who have severe malaria and are not treated, 90% will die. In 2017, which is the most recent year for which we have global malaria data, there were over 200 million cases of malaria worldwide, the vast majority, over 90%, in Africa. And there were also about 435,000 deaths from malaria, almost two-thirds, 60%, among children under 5, who are particularly vulnerable to malaria because their bodies haven't developed immunity to the disease yet, which protects older children and healthy adults. Now, this is the kind of environment in which mosquitoes thrive. They like it hot, they like it lush, they need pools of water to breed. So in tropical areas where it's hot year-round, where rainfall is common year-round, malaria transmission will be high all year round. There's things we can do to prevent and control malaria to a certain extent. We can make sure that people have access to bed nets to sleep under. We can spray houses with insecticides to repel the mosquitoes, and we can make sure that people who do get sick receive prompt diagnosis and prompt treatment. And Malaria Consortium, the organization for which Diana and I work, is involved in all those interventions in Africa and in Asia. Now, based on what I told you about the kind of environment mosquitoes like, you might think that there's not much work for us to do here. It's dry. Mosquitoes don't like dry heat. And you'd be right for most of the year. However, for about 4 months every year, this area actually looks like that. That's the rainy season. It's about 3 to 4 months every year. And mosquitoes do like the rainy season. So what we see in these areas is that malaria transmission is quite low for most of the year, and then during the rainy season, it just shoots up. And that's a pattern we see across most of the Sahel zone. So that's a band ranging from Mauritania and Guinea in the west to Chad and Sudan in the east. And in those areas, the World Health Organization recommends an additional intervention to prevent and control malaria, and it's called seasonal malaria chemoprevention, or SMC. SMC involves the regular administration of antimalarials to entire populations, so regardless of whether they're infected with malaria at that point or not, during the period of greatest risk. Now, in practice, what that means is that we give a combination of 2 antimalarials to children under 5, because they're the most vulnerable, in monthly intervals from July to October, which coincides with the rainy season. What does that actually look like on the ground? So this is a community distributor. She's a volunteer from the community that she serves, and she will go door to door in her community and identify children under 5. And she will carry blister packs, just like this one. Those of you in the front row, you might be able to see there's 4 tablets, there's 1 white tablet and 3 yellow tablets. Remember earlier on I told you we're using a combination of 2 different antimalarial drugs. And she will take the white tablet and 1 of the yellow tablets, and she will disperse these in a little bit of water, and then she will give it to the child. Now, if or when the child spits out the drug, and you can probably imagine that does happen, because children don't like to take medicine. Well, no one does for that matter, but children especially. And also, to be perfectly honest, the yellow tablet in particular doesn't taste very nice. We actually worked with the manufacturers in the past to sweeten the taste of the drug and to give it almost a gummy bear-like orange taste. But it's still not the most pleasant of experiences, right? So when the child spits out the drug, then the community distributor will give a replacement dose. And then over the next 2 days, the parents will give the remaining 2 yellow tablets to the child. And if the drugs are given correctly, then the concentration of antimalarials in that child's bloodstream will be high enough to kill mosquitoes for about 1 month. So in a month's time, the same community distributor will come back to the same household and give the same drugs to the same child. And we'll repeat that 4 times over the course of the rainy season. Actually, right now, the last of 4 cycles of SMC is happening as we speak across the Sahel zone. So what's Malaria Consortium's role in all of this? Well, we were involved in SMC from the very early days. It's actually a fairly new intervention. It was only recommended by the World Health Organization back in 2012. In 2013-14, we were involved in some of the early pilots in northern Nigeria, reaching about 500,000 children, which showed that the intervention can be implemented at scale. And we then led the very, very rapid scale-up of SMC across the Sahel zone in a project called Access SMC, where together with our project partners, we reached just about 7 million children in 7 countries across the Sahel zone. And then from 2018, we continued implementing SMC, mainly using philanthropic funding in Burkina Faso, in Chad, and in Nigeria. And much of that philanthropic funding, most of that philanthropic funding, is coming our way because we were given top charity status by GiveWell. In 2019, we're reaching just about 6 million children in those 3 countries. And as I say, the campaign is happening as we speak. So as I'm standing here, there'll be community distributors going door to door and treating every child under 5 that they can find. We're still planning to reach even more children over the coming years, because despite our best efforts and the efforts of other implementers, other funders, there are still areas that could benefit from SMC that are not currently reached. Now, very practically, what do Malaria Consortium do? We provide technical assistance to ministries of health, to malaria programs. For example, we develop guidelines, we develop job aids like this one, which shows how to disperse those tablets in a little bit of water. We're involved in training community distributors. So you can imagine, to reach 6 million children, there's a big machine that's required there. So this year, for example, we were involved in training around about 76,000 people across the 3 countries where we work. Much of our work is about managing commodities. So we procure these drugs from a manufacturer who's in China, and then we oversee the delivery of those drugs across the Indian Ocean, much of the African continent, to West Africa, to central medical stores in the countries where we work, to the district level, and to health facilities in the 3 countries where we work. And that's where the community distributors pick up the drugs to then distribute them to children. So there's a lot of work that's involved in managing that process. And because, as an organization, we believe in evidence-based interventions, we're also committed to contributing to the evidence base. So we collect and analyze routine monitoring and evaluation data, and we also carry out research to try and improve the effectiveness and the quality of the SMC program. Now, I'm still relatively new in this role. I started working on the SMC program back in May this year. And the thing that's really struck me and that's moved me was what a transformational program SMC can be. It's transformed the way we prevent and control malaria, because it's added to the fairly limited number of interventions that we have at our disposal to tackle malaria. And it responds to a trend to tailor interventions to specific contexts. So this is specifically tailored to areas where malaria transmission is seasonal. But more importantly, I've seen firsthand how the intervention, the program, can change people's lives in the areas where we work. And don't just take my word for it. Here's what Chantal, she's a mother of 5 from Burkina Faso, here's what she said about SMC.
Je m'appelle Chantal. J'ai 5 enfants. 3 prennent les médicaments de la CPS depuis 3 ans. Avant la CPS, les enfants étaient tout le temps malades. Depuis que les enfants prennent les médicaments de la CPS, ils ne tombent plus malades. Grâce à la CPS, j'arrive à économiser un peu de l'argent parce que les enfants ne tombent plus malades. Si on arrête la CPS, les enfants vont souffrir.
So as Christian has explained, over the last 5 years, SMC and Malaria Consortium have gone through a transformation. And I want to tell you a bit more about that journey. It was a journey that really started by chance. In 2012, one of my colleagues came across GiveWell, and their focus on evidence and data analysis really resonated with us, given that, as Christian has explained, we are a technical organization in word and deed. So we started looking into their approach. However, it became clear that GiveWell's perception of us was that we were focused only on providing technical assistance and carrying out operational research, but we needed to present to them more evidence of our work, of the work that we did on the ground. We spent 9 months sharing reams of information with each other, project data, analysis, results, and reports, and we had many, many long phone calls. And it's worth noting that traditionally, Malaria Consortium has been funded by governments and institutions, and we work with USAID, with UK Aid, with the Global Fund, and with the Gates Foundation, for example. And with GiveWell, we assumed that we were entering into the same sort of donor relationship, but we were mistaken. It was soon clear that it was quite different. The depth of analysis was completely new to us from a potential donor. So we found ourselves learning from this experience as well. For example, as we drilled down into the details of the cost-effective analysis, we found that interventions which focused on children under 5 are actually less cost-effective than those interventions which include adults. So GiveWell and Malaria Consortium didn't always agree on everything, and there was much healthy debate, but we found alignment, and I think it's fair to say that the journey we're now on together is both challenging and insightful. And it's a journey that introduced us to the EA community. So your adoption of GiveWell's recommendations, and therefore your support for our SMC work, has helped us to build the evidence that SMC works at scale, a scale-up we were able to do super fast because of that support. And you've helped us to keep to that scale, although, as Christian has said, there is still more that we need to do. So this rapid scale-up has also greatly multiplied the demand for the drugs used, and before we could expand SMC coverage, our chief executive had to travel in person to China to meet the world's only manufacturer of the drugs and persuade them to increase production so that there would be enough. And thanks to what is now clear demand across the Sahel region, we expect new manufacturers to come online soon. So the programme has been truly transformational on many levels. Right now, 6 years since we first trialled SMC, we're reaching 6 million children every day, every year. Sorry, every day, wouldn't that be good? Every year. And it's not only about saving lives. The positive economic effect from the prevention of malaria on households, as Chantal has pointed out, well, she refers to it, and on national economies is huge. In settings with seasonal malaria, the rainy season is a time when adults should be out in the fields planting and carrying out agricultural work. But if a mother is caring for a child with malaria and not spending time on the farm, the economic costs can be crippling. Not only from loss of productivity and therefore income or earnings, but also because of the unplanned costs associated, such as for medicines and travel. So with our traditional funders moving to focus on service delivery rather than program co-design, we now find ourselves competing with consulting firms instead of other NGOs. And this squeezes costs, and NGOs struggle for the bandwidth to be creative and innovative. Through the EA community, however, Malaria Consortium now has new options and new possibilities for partnership. So you have catalysed an organisational shift in the way we now see our future as an organisation. And this is a really exciting outcome. So Christian and I have told you in some detail about the impact of the SMC programme, because we want you to be inspired by what you have helped us achieve with your support and to see how far we have come. This is so that we can continue our journey of change and impact. We aspire, the impact you've helped us to achieve makes us aspire to new creative relationships with the EA community so that you will see us as a partner for the future. We want to test out new ideas so that we can lead the next scaled intervention that will disrupt the status quo and save lives. We want to find solutions to stop people dying or being debilitated by diseases of poverty. And I'm talking about malaria in pregnant women and infants, pneumonia, diarrhea, which are bigger killers of children of under 5s and young children than malaria, and even one of the neglected but fastest spreading tropical diseases, which is dengue. We want to pioneer new tools and innovations, such as the new malaria vaccine in seasonal chemoprevention once it's ready for scale-up, or aids for diagnosis and treatment of pneumonia in the community, or the new or next generation mosquito nets. We want to share information and best practice on the tools and ways of working that already exist but haven't been properly analysed for most effective use. We don't have to keep reinventing the wheel. Sometimes we need to be consistent and change small things, such as asking the drug manufacturer to sweeten the pills so that the children don't spit them out. You already know that the EA community brings with it great transformational power. You've heard how the support from GiveWell and the EA community has allowed us to bring about huge and lasting change with SMC. So I ask you, how will the EA community use this power going forward? And what change will you help us bring about next? Thank you.
But I just wanted to say I found it really fascinating to hear about the process of your organization working with GiveWell and how that's changed the way your perspective and your methodologies. And I think that that is really of interest to a lot of people in this room who are intimately familiar with GiveWell, and many of us use it sort of as a guiding light. And I'm interested to hear if you think, is there one particular sort of outcome of working closely with GiveWell that you think is maybe going to be the most influential thing as your organization continues to move forward?
Well, I think, as I alluded to in my presentation, I think the biggest outcome has been how it has transformed the way we look at philanthropic giving. This has never been something we've received before. We don't have a public membership base. We get all our funding from traditionally from governments and from institutions. So to have this opportunity to scale up something so important through philanthropic sources is made us completely rethink how we can do more of that in other ways and with other relationships that we'd like to build, partnerships.
And Diana's sort of presented the organizational perspective here from the point of view of the specific program that we're implementing with philanthropic support. I think one of the biggest differences really is the level of flexibility this is giving us. In traditional institutionally funded programs, there'd be a lot more requirement on us to comply with certain donor regulations, whereas the philanthropic funding is really enabling us to make decisions about where we want to go with this program, geographically, but also in terms of the scale and the scope of the program. And that's just a lot easier with the kind of support and the kind of relationship we have with GiveWell and the philanthropic, the EA community in general, than it would be with traditional institutional funders.
Fantastic. That's great to hear. Well, thank you both for this presentation. If anyone else has further questions, I'm sure you can find them after this talk. And thank you for being here this year. We really appreciate it.